Good morning and thank you. Welcome everyone, local and from farther afield. My morning started today at 4 and I drove in, had a beautiful drive in from Kingston. So if any of you did any traveling, I would say I hope your morning was as lovely as mine. In terms of the talk today, what I've tried to do is combine information from a number of different training sessions and workshops that I've offered to various groups across the province on the topic of elder abuse and dementia. And so I'll try to condense as much of what takes maybe several training days into this hour, hopefully to whet your appetite, but also to give you some key points that you can take away and make use of. So in terms of the goals and objectives for the session, I'd like to start with just a little bit of reflection on what our own perspectives of aging are. And then we'll look at some of the unique issues and constructs posed in the cases of abuse where the person also has a diagnosed dementia. And then finally we'll look at some risks and also strategies. And I'd like to focus on both unpaid or family caregivers and also then look for residential settings where paid caregivers are involved. So in terms of aging, what is it that we see? Well, if you're a senior yourself, you probably identify as someone with passions and activities in your life. You identify as someone who feels passion and love. You might be someone who's excited about technologies and new ways of changing in the world. If you're a young person, when you think of seniors, you may think of someone like your great-aunt Gertrude in her pearls and poised. As clinicians, we often consider individuals who are seniors as folks who might be worried and confused. We might see them when they're frail and sick. And people come to us, those of us who are service providers, seniors come to us in some of the most difficult and vulnerable points in their lives. And they entrust us to help them through what can be a very difficult journey at times. Sometimes we forget, though, that that's not the entire slice of the senior population. And just to remind you, I wouldn't mind being a grandson or granddaughter of Tina Turner and saying, that's my idea of senior. So any and all of these perspectives of seniors are correct. So seniors are as diverse, complex a demographic as any other. And depending on your perspective, sometimes you may have a little bit of a narrowed view, but I think it's important to keep in mind just how diverse this group is. I want to just step back a little bit and lay some foundation work here. In terms of ageism, what used to be called the Ontario Network for the Prevention of Elder Abuse, now Elder Abuse Ontario, defines ageism as a discrimination that occurs on the basis of age, which makes certain assumptions about a person's capability, oftentimes removing them from their own decision-making processes, ignoring the older person's wishes, and can include treating a senior as a child. In terms of some of the demographics, life expectancy, as in all first world nations, is extending so that women live into their mid-80s on average, and men closely at 83. The other growing demographic is that portion of the population that's aged 100 years or more. And I don't know about you, but when I was a kid, it was a big deal on the news in the morning when somebody's 100th birthday was announced. And now it's far more commonplace. So we can see in 1996, excuse me, there were about 3,100 people in Canada aged 100 or more. And in 2006, that had risen to about 4,600. By the year 2031, we should have about 14,000 individuals in this country aged 100 or more. And that's That's quite an accomplishment. The other point, though, to that is that age, of course, is the biggest risk factor for developing a dementia. So that will also mean that as our population ages, and the oldest of the old make up more and more of that senior demographic, that we will also have a larger proportion of that demographic who will be developing a dementia. Turning to some of the elder abuse basics. The World Health Organization defined abuse of older adults as a single or repeated act or lack of appropriate action occurring in any relationship where there is an expectation of trust that causes harm or distress to an older person. And so you see that involves both family members, unpaid caregivers, and all of us who provide service in that relationship of trust. Causes of elder abuse. Really, we can break them down into three. As in any abusive relationship, it is usually about the issues of power and control, where one person is vulnerable and the other is dominating that person in some way. It is also caused by isolation, an isolation of either the person with the dementia or the person who's providing the care. And we'll talk about that a little further into the presentation. And the third, dependency. And again, that can fall on either side of the equation. It may be that the person with the dementia is dependent on the caregiver, care provider, but also in some cases, the care provider can be dependent on the senior with dementia. Sometimes it's for financial security, sometimes it's for emotional support. So there can be that two-way dependency that can occur. You're probably most familiar already with the types of elder abuse that have been identified in the research and the literature. I'll just quickly go over them. Financial neglect, violation of rights, physical abuse, sexual abuse, emotional and psychological abuse, and systemic abuse. And I'll highlight some of these that may be a little less familiar to you. We all think of the great ad campaigns to heighten our awareness about things like financial abuse with seniors, the commercials with the grandson who's basically extorting money from grandma on the street. We've seen those kinds of commercials. And again, hats off to Elder Abuse Ontario for doing a lot of that work. But in terms of some of the other aspects that you might be a little less familiar with, neglect refers to not meeting the basic needs of a person. And those are the kinds of stories that make it into the newspaper so often, like the tragic case of the woman who was freezing in a garage in Toronto, for example, living in the garage portion of the house of her son and daughter-in-law. So not meeting the basic needs. That can be active neglect, when you're withholding care or basic necessities, as in the case I just cited, or passive neglect, where the failure to provide the proper care really can come because the care provider doesn't know what to do, doesn't really appreciate that the senior needs that level of support, maybe doesn't have the capability himself or herself to provide that support. So that's neglect. Related to that, violation of rights. This becomes a little more tricky when you put it in the context of dementia, and we'll do that a little bit later. But in general, for seniors, violation of rights includes denying a person privacy in his or her home. And you can imagine, as a person's dementia becomes more and more severe, that privacy sometimes means that they're at greater risk if they're on their own. So it's a balancing act that one has to take into consideration. Withholding information to which the person is entitled is another form of violating a person's right and considered abuse. Denying a person's visitors, phone calls, restricting a person's liberty, censoring a person's mail. It's interesting, I just had a case recently about a family member who said to me, I'm starting to withhold some of Mom's mail because she'll perseverate on it. She'll get so distressed. It'll cause her to be up at night. It will completely ruin her next day. And I have to then look at if I can use some other strategies to calm her down. I'm up all night with her, so I have to start keeping some of the mail away from her. Do you think that's all right? So it's always this balancing act when you throw dementia into the picture as well. Physical abuse, you can see the slide. That's probably the most readily identified form of abuse that we come to think of. However, in addition to that, we should add medical or medication abuse, which can be things like either withholding medication, over-medicating, or under-medicating a person. And again, this applies to both family who are caregivers and also people who are in residential care. Similarly, we have to consider things like unnecessary chemical and physical restraint. And while there may be reasonable situations where it's necessary, that needs to be carefully assessed and also has to include appropriate consents. Emotional and psychological abuse. This is probably the most insidious of all of the types of abuse. And unlike the ones that get the greatest press, this is not predatory in nature. This is something that evolves, that arises out of the stresses and strains, out of the lack of knowing what to do, and suddenly the caregivers may find themselves responding in ways that they would have never expected of themselves. It includes things like your language that you use with the person you're providing care for, which are putting them down, are hurtful, are making the person feel unworthy. How can you be so stupid? Why don't you ever remember these things? They're so natural in a moment of frustration. Not considering a person's wishes, respecting their belongings, denying access, again, violation of rights, threatening. If you don't stop this, I'm going to put you in a home. Treating seniors like children. So these are the things that caregivers oftentimes will report. I didn't realize I was doing it. I caught myself and I couldn't believe that I said it, did it. The prevalence of abuse from Canadian statistics is anywhere from 2 to 10%, and I will tell you that anyone who does work in this area will say that that's a gross underestimate. There are anywhere between 32,000 and 160,000 reports in Ontario, 148 to 370,000 in Canada, and the rates are significantly higher for those with either or cognitive physical disabilities. So certainly the individual who has a diagnosis of dementia will fall into that category. There is also a general reluctance to report on the part of seniors. And this work really comes from folks who are either not suffering from a dementia or still in the early stages where there is certainly awareness and insight. So there is a real reluctance to report for a number of reasons. Some people don't recognize that the behavior is abusive in the first place. Some individuals believe that they really have a handle on this. It's their place to control the situation, and they don't want to involve anyone else. Self-blame. If I had been a better mother, he would be more willing to take better care of me, so it's my fault. And doesn't that resonate with any abuse population, where the abuse victim somehow thinks that it's his or her fault? Shame. Particularly for those of you who work in population groups that are multicultural. So many cultural aspects to take into consideration. Shame, guilt is a huge, huge one to consider. Fear of abandonment or retaliation. If I speak up, what will happen to me? Maybe I'll be placed in a home. Maybe nobody will believe me. There's nothing out there that can help me. This is our problem. Our family's problem. So, gross underreporting. For those who are at risk, Spencer's study in 2002, just sort of a general profile, those who are at greatest risk are those over the age of 75, those who are widowed or living alone and are socially isolated, under the influence of the person who is the abuser, and again, this comes up again and again, and I'll just keep driving it home, with some degree of mental or physical incapacity. This is a study from Statistics Canada, and when we talk about physical and cognitive impairment increasing the risk of abuse occurring, this study from 2009 shows the proportion of the population who suffer from one or more chronic diseases. And so this lower panel, the 45 to 64 age group, is represented down here. So 40% have no chronic diseases, and about 7% suffer from 4 or more chronic diseases. And we're looking at things like asthma, arthritis, rheumatism, cancer, Crohn's disease, glaucoma, thyroid, Parkinson's, Alzheimer's, so any chronic disorder. If you look at this far end of the graph, excuse me, and then over here, the 80-plus group, you have a mirror image. So about 40% of the 80-plus group wake up every morning and have 4 or more chronic diseases to deal with. So that means I can get up and be diagnosed with a dementia, so I may suffer some confusion, I may suffer issues with memory, I may have problems with organizing myself for self-care, but I'm also diabetic, but I also have arthritis, but I also have Crohn's disease. Let my day begin. And if any of you have even one chronic illness that you're dealing with, imagine that plus another 3 with somebody who's 80 plus. So let's start talking about the specific context of elder abuse and dementia. And I'll start with family caregiver scenario. There was a study done by Cooper and Group. This is in the British Medical Journal in 2009. What they did in this study was asked 220 carers, in Britain they refer to them as carers, of individuals who had a family member diagnosed with dementia. And they asked them to indicate any or all types of abusive behavior that had occurred at least sometimes in the previous 3 months. So this is self-report from caregivers, family caregivers. Over 25% of them reported having screamed or yelled at the person that they provide care to. Almost 1 in 5 used a harsh tone, insulted, or swore at the person. That's the environment in the household. And then the others that were the most often reported, less than 5%, threatening to send someone to a care home, afraid they might hurt or hit the care recipient, threatening to stop taking care of or abandoning the care recipient. Same themes as we saw earlier. You'll notice that the top 2 are the emotional, psychological abuse. Okay? Not the physical, not the financial, the emotional, the psychological. And the other point is that over half of the carers in this study reported that they had engaged in some sort of abuse within the past year. They could identify something of the selections that they had engaged in. A third of them had reported that they had engaged in the last 3 months in something that they would term important abuse, something that made them step back and say, oh my God, what am I doing here? So some of the identified factors related to that care provider, care receiver dyad. What are some of those factors that heighten the risk? When the care receiver was living with a family member who was not a spouse, so adult children primarily. When the caregiver himself, herself, was battling depression, That increased the risk. And there was more risk of abuse and more rates of abuse when the number of hours in which care was provided increased and the person had greater functional impairment. And I want to highlight that in particular because I'd like to share some research coming out of our lab in Kingston that looks at this as well. So what it says to us is that as the dementia progresses and caregivers are providing more care to somebody who is more impaired, their risk continues to escalate. The risk factors for becoming an abuser, so from the perspective of the care provider, living with others, so if you're living in the same place as the person you're providing care for, if you yourself are socially isolated, you don't have a lot of outlet supports, if you're struggling from a mental illness like depression, if there are alcohol or drug issues, long-standing hostility and anger problems. Remember, we don't all fall into the relationship of either being the care recipient or the care provider without our own personal histories. So we come with all of our warts, we come with all of our issues. Being a spouse or being a child, increased rates. As I mentioned before, if you yourself as the care provider are dependent on the older person, you've lost your job, you've moved back in with mom. And also if you yourself as the provider of care are a victim of childhood abuse. Selwood did a very interesting study looking at what care providers identified as protective factors. So what they felt would be useful in protecting against abuse developing. They thought medications for memory would go a long way. And I'd have to agree as soon as we have them available. Good communication from professionals. Talk to me about what I need to do, what you're going to do, how this is going to play out. Having documented, written advice, strategies on how to deal with some of the memory problems. And you can see that from a care provider's perspective, memory is still sort of a dominant theme, whereas as clinicians, I think we would say that the behavioral issues are far more a dominant theme. Availability of home care and respite services. It's really not respite if it can only happen on the professional or the organization's terms and not on the terms that the care provider needs. So if we can address the caregiver issues, we're going to address the risk of abuse evolving. And so what I'd like to do is, in addressing this, is talk to you a little bit about some of our research that looks at the relationship between caregiver stress and the behavioral and functional change in dementia. The Kingston Caregiver Stress Scale is a scale used to monitor change in caregiver stress over time. This is the caregiver stress scale. It's on the Providence Care website. It's easily downloadable and free to use. It's 10 questions rated on a 5-point scale. Stress is divided up into 3 areas: that related to caregiving, that related to family, that related to financial. And we've seen consistently that caregivers are able to compartmentalize their stress. So just because stress may be elevated in one area doesn't mean it will be elevated in all areas. People can really describe clearly what is triggering their stress. And we looked at the stress scale and paired it with the Kingston Standardized Behavioral Assessment, or KISBA. And the KISBA is a checklist. It's a 68-item checklist, the community version. There's a long-term care version. Also, it's on the website, easy to use. It's completed by the caregiver or long-term care institutional staff, and it breaks up behaviors into 12 domains. So for each KISBA, you get a visual profile of elevated domains. And the KISBA, as far as we know, is the only scale we've found that actually looks at a consider placement decision. This line on the graph, for folks who live in the community, is that level where caregivers have said to us, I have exhausted everything. I've done everything I can. I have every service in the house. I have community supports. I have day programs, and I'm at my limit. I think maybe it's time that mom, dad, my husband needs more care than I can provide at home. The beauty of this is that it doesn't come from the clinician. Who am I to tell you you should be looking at placement? This is what care providers have said to us. So we can say when we administer the Kisba, you're at a level where people in your position have said to us, I'm starting to feel maxed out. Do you think it's worth having a conversation about placement? And it actually ends up being a far more receptive notion than if it's directive from the clinician. We looked at a study a few years ago at the progression of behavior in dementia, and we looked at over a couple of hundred people, cross-sectional study, looked at how their Kisba scores changed. And what we found was that there was quite a predictable pattern using a cross-sectional design of how behaviors emerged as the dementia progressed. What we developed is a chart, this is on the website as well, that we've distributed to family physicians primarily to use as a discussion tool. So the family member fills out the Kisba and you identify where on the chart they fall. Are they mostly green? Are they mostly yellow? Are they mostly red? And you can, in this way, describe what behaviors are occurring, what behaviors are likely to occur next. So if you're in the early stages and most of your behaviors are in the green range, the next ones that you might be looking out for, if you notice any of these, this might be indicating that there's a progression of the disease. So heads up for you, and we should talk about what we can do to offer you support. So it's a useful tool. The feedback we've received is that it's a useful tool for clinicians to practically talk about behavior change. So we looked at the relationship between caregivers having filled out the Kisba and then also filling out the caregiver stress scale. And what we found that the overall correlation was 0.82. The greater the behavioral change, the greater the caregiver stress. And in particular, that stress was related to, no surprise, the care-related activities. 0.83. So as the person becomes behaviorally more impaired and there are more functional challenges, there is more and more stress on the caregiver. While there were correlations, significant correlations with the other two dimensions, not trivial, I point out that really it's about providing the care. So what supports can we provide then for caregivers? Well, we need to ask, where do the caregivers acquire the knowledge that they need in order to do what they need to do? And how can we supplement that? So skills-based training, knowledge is important. Is there peer support available to normalize the process, to vet some of the feelings, thoughts, questions, to put some perspective, to not feel like you're the only one going through this? Providing real respite, relevant respite, and also helping with moving towards that transition to long-term care, because we know that's always a huge crisis point for both the care recipient and the care provider. Lest you think that these are just trivial changes, Roger et al. Did a very interesting study looking at community service providers who went in and provided these kinds of supports to caregivers. And they found that community service providers could be trained to deliver effective, evidence-based caregiver interventions right in the home, and the interventions address the issues of caregiver depression, burden, stress, and also improve quality of life for the patients. So yes, we can be effective. Yes, there are things that we can do, and we need to be addressing those issues that caregivers identify. In the remaining time, I want to talk a little bit about long-term paid caregivers. For the last year or so, I've been asked to give several workshops to long-term care facilities on potential for abuse. And the talk that I usually give is some variant of, I'm a service provider, could I be an abuser? What if the answer is yes? And I would argue the answer is yes. So if we come out with that opening point that if I'm a care provider, yes, there is some risk that I could also be an abuser. We lay it out on the table and it becomes an honest discussion rather than some sort of dirty secret that no one really wants to talk about. In terms of some of the issues with long-term care, residential care, paid caregivers, it's a tricky balance between that patient and person continuum. Again, when we see patients when they come to us, they are at the most challenging points in their lives. They are the most vulnerable. They are the most afraid. They are the most impaired. And their personhood sometimes gets lost because we're so focused on the diagnosis. And yet that personhood is oftentimes the key that unlocks all of the important strategies that we can make use of. So sometimes people really do need acute attention as patients, but nobody wants to be a patient 24/7. That personhood has to be part of it. When we lose that personhood, we go off into the realm of dehumanization. And I say this is not orthopedic surgery because if you've ever worked with orthopods, they are very fixated on the body parts that they are treating, as they well should be. And they're really not that worried about, how are you feeling today? And that's fine if you're having a hip replacement. It's not fine if you're providing care. It's called care for a reason. Dehumanization, the definition, is the denial of humanness to others. I think that's so very important. And in the literature, they talk about animalistic dehumanization, which is more applied to groups in general, and then mechanistic dehumanization when we're talking about an individual basis. So things like using language that takes away from the humanness of a person, physically abusing someone, doing something simple as not making eye contact with them when you're providing care is a way of dehumanizing them. Ignoring the target, the person's individuality, personhood. And what all of that does, if you stop thinking of these patients as people, as individuals, is that you stop finding your compassion. You stop finding the caring part of care. One of the things that contributes to that in the residential environments is an assembly line approach. Everyone has their morning cares done in the morning, in this way, in this many minutes, because we have to get everybody done. When you see your residents, clients, patients as a set of widgets on an assembly line that have to get done, you lose the humanness. The other thing that clinicians, care providers deal with on a daily basis are the things that you take home with you, the things that are a part of your makeup, that if you work at McDonald's in the drive-thru, if you're an accountant, well, you're stressed because it's tax time, but you're an accountant, you're a clerk, you don't see deterioration, fragility, infirmity, and dying on a regular basis. But we do, and we carry that with us. And that's not something that you carry freely without an effect. So we carry this with ourselves, and that also can make us a little more vulnerable as care providers. And also workplace violence. In a study that looked at long-term residential care for seniors, a majority of healthcare workers experienced at least one incident of physical violence in the last year of their work. And I read this study and I went, only one? The rates of workplace violence are so high with this population. The confusion, the agitation that results in being kicked, spit at, hit, punched, having things thrown at you. And oftentimes healthcare providers just become complacent and think it's part and parcel of my work. And it also contributes to dehumanizing the person. thinking of them as someone who's simply a perpetrator of these things randomly. And then in our residential settings, we also have administrative and systemic issues. Things like caseload, how many patients, what is the patient ratio, what is the case mix, how do you determine if you have so many heavier patients, so many lighter patients? Where's the discussion about that? How is that determined? What constitutes a fair caseload? The issue of resource scarcity. There's the ongoing debate, there's the ongoing coverage issues of incontinence products, for example. If you've done any work in long-term care facilities, you know what a huge issue that is. And oftentimes, I don't know how many care providers in long-term care homes have said to me, it's just not right. It's just not right. And again, as care providers, you carry that. You carry that with you. So, some practical strategies for those paid caregivers. Assess. Ask the hard questions of yourself. This is one tool, the Professional Quality of Life Scale, the ProQOL. It's a 30-item self-assessment tool. You get 3 scores. It looks at issues of compassion satisfaction, compassion fatigue, secondary trauma, and burnout. There's not time to go into all of it. You can download the instrument. It's easy to find, so the ProQOL. Only one way to ask the tough questions. How am I doing? How am I really feeling? Let me pause, let me reflect. And maybe that opens the door to having some discussions. Within the facility where our paid caregivers work, is there a safe place to voice concerns? Addressing caseload, it's just too many to do in the time allotted. I always seem to get more heavy cases than I can manage. What can I do to change this? Is there something I'm doing? Is there something systemically we can do? Is administration open to having those kinds of discussions? Or to creative problem solving, for example? Is there a safe place to vent? I can't work with George. George reminds me very much of fill in the blank. I just can't work with him. Can I trade off? Because every time I see George, I'm flooded with memories, what have you. I've had this person on my caseload for a long time, and I really need a break. Can you identify if you're feeling at risk? You know, the last couple of months, as I'm doing my cares, I'm finding I'm getting less and less patient with my patients. What can I do? I don't like the way this is making me feel. I need to know how to do this better. I don't know how to, as well as other people, because I notice when I have Millie, it doesn't go very well for me. But I seem to be the only one who's having this problem. So what am I doing? What can I do differently? So if the answer to any of those questions is no, you don't ask those questions. No, there's no safe place to have those discussions. That's your starting point. That's one of the big issues. And then coming back to the initial point, the patient person, bringing it on back home and recognizing that this is a person, bringing back the personhood into your clients, your patients. I do training in behavioral care planning, and I will always say to folks, no 2 behavioral care plans should ever look alike, because no 2 people ever look alike. You can use the same model, you can use the same constructs, but no 2 care plans should ever look alike, because they will draw on a person's past interests, hobbies, vocations. It will look at the things that are sources of pride for them, of old learning routines, of old habits, of the values of the individual. For somebody who maybe only has few pleasures left in life, one being food, what do they like to eat? What do they hate to eat? Don't offer that up. What are the customs of that particular individual? And suddenly the person's not a widget, but the person is all of that rich fabric that they've been all of their lives, and to so many other people. When I read this out to you, I always like to include something that's a little inspirational in talks that I give. This is from the Alzheimer's 911 site. It's an Alzheimer's prayer, and it's just something to reflect on. So this is from the perspective of a person with dementia. Dear Lord, they say I'm ill, and that's why I can't remember. Help me always to feel I'm always held safe in your heart. I just want people to be kind. I want to belong somewhere safe. I want to be treated with respect. I want slowness and time for everything. I want people to look me in the eye, sitting right next to me, an arm around my shoulder as if they cared about me. I hope you can help me find the love I need. If you can't send my mother or father to me, please send someone just like them, someone who will love me exactly as I am. Because, you know, Lord, I would remember if I could. I would do things right if I could just remember how. I would be that person that once I was. I would, but now I can't. Please walk with me all the way so I can find my way home at last. From the talk this morning, I hope the things that will stick are that dementia represents a particular risk factor for elder abuse, that behavioral change is associated with progressive dementia increases that risk of abuse occurring, and increases caregiver stress, and that's really the mechanism or the mediator. When you address a family caregiver's limits, their skill deficits, their supports, their needs, you will reduce the stress and you will lower their risk of becoming an abuser. And for residential long-term care staff, they are also at risk of abusing their patients and residents. Firstly, recognizing this and not seeing those who abuse as being someone who could never be me is an important starting point, and providing them with the safety to explore what they need. Thank you.